Okay, hope everybody had a good break. Just a little information. If you haven't registered, please do so at the registration desk. We need your signature to show that you were here, an email address, since this is how you're going to get your STEAMI and C&E credit from their respective offices. At this time, we'll have Dr. Fernando Membreño do 2 talks in a row on cirrhosis. The first one will be, how do you manage the complications and when to refer to a liver specialist? And the second will be, who gets cancer and who needs a liver transplant? Dr. Membreño.
Well, thank you, Teresa. This is certainly a very exciting time. And if you think you've heard good lectures in hepatitis C, now you're for a treatment for cirrhosis. And although you can think of it as a failure of not having treated this liver disease in the past, just as a poll, can you raise your hands if you are primarily doing primary care? Okay. And if you are in a specialty, a non-liver specialty? Okay. And if you're a liver specialty or a transplant center. Okay, so we have a pretty good mix. All right, so I'm going to take you through, these are my disclosures, I'm going to take you through cirrhosis, and I also do the Eric trick here and get out of the podium. We're going to talk about cirrhosis, and I'll try to give you some management perks of how to tackle these patients that sometimes can be difficult to handle. We'll talk about epidemiology all the way to treatment. So what is important about cirrhosis? And Gary Davis did this very good study in which it projected the cirrhosis rate since 1960 to 2030. And as you can see, in the 70s, we could barely see F4 cirrhosis, F4 fibrosis. As time goes on, in 2020, we expect that we'll have the peak of cirrhosis, right? And that has to do with our failure of preventing the development of scar tissue in the liver. And that may change, and we expect that the advent of new treatments for hepatitis C will bring a drop to this bad trend of increase in cirrhosis. So the problem is that as the cirrhosis rate increases, we also see an increase in the decompensation rate, and we also see an increase in the liver cancer rate. And that's very important to keep in mind. They go hand in hand. So how do we diagnose cirrhosis? And cirrhosis can be an easy diagnosis sometimes, most of the time, but it also can be a tough diagnosis because it's a mixture of things, right? You have to mix your physical findings with your laboratory findings, with your radiological findings, in order to try to come with a diagnosis. Rarely, we're going to need a liver biopsy. Most of the time, we won't, because you'll see a shrunken cirrhotic liver in a radiological study with low platelets. It's like almost like a no-brainer, right? The problem is that many times you won't have those features, and you will see rather smooth ultrasound, the platelets maybe in the 160s, and it becomes a little bit more confusing. Sometimes, at that point, we might go to a liver biopsy, or when we have a doubt of what may be the cause of cirrhosis. And as you heard before from the prior speakers, now we have other ways of measuring fibrosis too, which is the FibroScan, MRI elastography, and some blood tests. So talking about the natural history of cirrhosis, let's see. There is 2 methods, essentially, of how we measure the function of the liver. And one is the Child-Pugh score, which was developed many years ago by surgeons trying to predict mortality in the OR. And that will take the factors of hepatic encephalopathy, ascites, bilirubin, albumin, and prothrombin. It will give you a result, and we classify them in Childs A, B, and C. Child's A is typically your compensated cirrhotic. So this is the cirrhotic that has no symptoms. Child's B and C are your decompensated cirrhotics. On the other hand, since 2002, we adopted a new method of trying to evaluate liver function, and that was the MELD score, so the model of end-stage liver disease. And this is a score that takes into account the creatinine, the bilirubin, and the INR, gives different weights to them, put it in this easy equation, a logistic regression equation, gives you a number between 6 to 40, 6 being the most normal you can get, 40 the most sick you can get, and it gives you a prediction of the 3-month mortality, going all the way from 90% to 7%. And that is how we currently allocate liver transplants in the United States. Having some problems here with, well, that slide would talk about a very important point, which was decompensated cirrhosis. So liver disease, cirrhosis is a spectrum. It starts with compensated cirrhosis, which is anyone that could be walking around without any symptoms and then is found to have cirrhosis by a blood test, by a ultrasound, but he doesn't feel anything. Those are our compensated cirrhosis. As we go in the spectrum of cirrhosis, there we go into liver failure. And when we start seeing liver failure, that's what we call decompensated cirrhosis. Liver failure, meaning presence of ascites, patient can be jaundice, can have variceal bleeding, hepatic encephalopathy. So what is the main problem with cirrhosis? And those are the complications of portal hypertension. So portal hypertension is derived from an increase in the resistance and the blood flow. So essentially in cirrhotic patients, you have a pooling of blood into the splanchnic system, right? And once you pull all the blood towards the center of the body, then the periphery of the body, the effective blood volume falls. So the body actually thinks that you are kind of dehydrated, that you're bleeding out, right? So it kicks up all the systems that will retain water and sodium. All the renin, angiotensin, aldosterone systems are kicked in, and that's why there is so much fluid retention with portal hypertension. On the other hand, as the flow increases into the liver, there is a resistant liver because there is fibrosis. So we develop sinusoidal hypertension in the liver. And from that, we see complications such as ascites, and we also see complications such as varices, right? Varices are the ones that we are most interested in, those that develop in the esophagus. So this is how varices look. And you can see the first picture is a normal esophagus. Second picture are small varices. And third picture is like a no-brainer. It's a large varices. And the interesting thing on the third picture is that you can see some red spots in them, and that means that the wall tension is high. So there is more imminent risk of rupture of those varices than the varices that are small. So that's why we have screening guidelines to look for this varices in every cirrhotic patient. So just when you see someone who has cirrhosis, just think, does this patient have esophageal varices? And this will occur in about 30% of patients. So what is the problem? The problem is bleeding, right? So one of these varices may rupture and bleed. So then we go with our great scopes down there, somehow always in the middle of the night. And we go there, we target that varix, and we deploy a rubber band around it. So that's called band ligation, right? With that, we stop the bleeding, but also this will eventually slough off, will leave an ulcer behind, and it will scar down. And amazingly, that takes care of the varix in the distal third of the esophagus where the bleeding is most frequent, and it doesn't impair the swallowing, which to me has always been amazing. And that has to do because we're only at the mucosal level. We're not touching the inner layers of the esophagus. So this is how we manage varices and what treatments we give. And essentially we give two kinds of treatments. We're trying to make a decision whether to give beta blockers in these scenarios, particularly when we have more decompensated liver disease and small or medium varices. And if they're large varices and have those red spots, then that is when we go and band. And we can do that in a preventive way. So even those who have not bled before, but they have big veins and they have spots in those veins, we should be banded those patients because we know that the risk of bleeding is high. So let's move on to ascites. So, and I'm sorry all these slides are not coming out as they should, but good that I know them by heart. And so ascites. Ascites is one of the main complications of liver disease, and it can become very difficult to manage, right? It has to do with the sinusoidal hypertension at the level of the liver, right? That creates a series of chain events that also lead to decreased blood flow into the kidneys and more retention of salt and water. The way to manage this was here. Let's see. They're out of order. So the way to manage this is diuretic therapy, right? And our diuretic therapy is mainly potassium-sparing diuretics, such as spironolactone and amiloride, and loop diuretics, such as furosemide, Bumex. So furosemide, we typically use in a concerted way with spironolactone. And we start in a ratio of 40 milligrams of Lasix to 100 milligrams of spironolactone, as per the AASLD guidelines. And we increase that progressively in order to control the volume of ascites. So we can go as high as 160 milligrams of Lasix and 400 milligrams of spironolactone. And if those fail, then we can go to other modalities. The problem is that when we're starting to see that diuretics don't work and patients are still accumulating water, then we start thinking something is going on, right? There's either a decompensating event, maybe they're having an infection in that fluid, right? Maybe they're developing SPP, or they're becoming refractory to the treatment. And that may be in two flavors. You might become refractory because you're intolerant, because your kidney function is now decreasing and your creatinine is increasing, or you're just becoming tolerant to the diuretics. So that leads to what we call refractory ascites. And remember, I was talking about how cirrhosis is a spectrum, right? Where we start with compensated cirrhotic, we move to decompensated cirrhosis, and then we go into refractory ascites. So in our mind as hepatologists, that is a higher level of liver dysfunction, right? So at this point, we're starting to think, hey, this patient's MEL score is probably increasing, and we're starting to think this patient may need a transplant evaluation, right? The only two treatments that are effective for refractory ascites are serial paracentesis or the placement of a transjugular intrahepatic portal systemic shunt, right? Nice name, huh? And essentially, this shunt is what we used to do surgically before with the distal splenorenal shunts. Now they can be done just by interventional radiology. They go through the jugular vein, they poke the liver from the inside, and they connect the portal system with the systemic system, as you can see here. And that decompresses the portal vein, and all the complications of portal hypertension start going away. So the ascites gets under control, the varices disappear. It's so impressive to see big varices just go away. And that's why we use it in also refractory bleeding. When we have bleeding that we cannot control, either because they're gastric varices that have ruptured and we don't have a good endoscopic method of controlling them, Or if the esophageal varices, we think, or we cannot control the bleeding, right? An emergency TIPS can be life-saving at that time. Of course, it has its own complications, and those, most importantly, are the onset of hepatic encephalopathy and liver failure. So we don't do TIPS typically on patients who have a history of severe hepatic encephalopathy or who are yellow, right? We don't like to put TIPS in yellow people, right? Only in very, 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 very small circumstances. Renal injury. Well, there was a big complicated slide here. It's good that you're not seeing it. So the message here is that renal failure, renal injury is very important in decompensated cirrhosis because, again, once we go from compensated to decompensated to refractory ascites, we go into renal failure, right? So it's at the end of the spectrum. And at the very end of the spectrum, we have death or liver transplant, right? So kidney injury in liver disease is bad news. And it's bad news because of these two great graphs that you cannot see either. But what we had here is that as your creatinine worsens, your survival is very dismal. And this one here showed the survival with decompensated liver disease against hepatorenal syndrome type 1. And this scale here is in months. And actually, if you get hepatorenal syndrome type 1, which is a very unique entity of renal failure in the setting of cirrhosis, the survival of those patients is about 2 to 4 weeks. You develop hepatorenal syndrome type 1 without any treatment, that patient will be dead in 2 to 4 weeks, right? And that speaks, and that's what this graph spoke about. So moving on into hepatic encephalopathy, that's another complication of liver disease, and it has to do with the buildup of ammonia. So ammonia produced in the colon by bacteria is metabolized by the liver usually, and our liver should be able to take care of that problem. But unfortunately, in liver disease, the liver is unable to metabolize that ammonia and goes directly to your brain. It causes what is like a mild cerebral edema. So it starts looking more or less like an Alzheimer-like picture, right? This is very scary for patient families, right? Because suddenly the patient goes to sleep and he doesn't wake up. So everybody thinks, oh, he had an MI, he's stroked, he's dead, right? So they call 911 and they take him to the ER. Sometimes this is the first presentation of cirrhosis. They find out that he's cirrhotic. They start giving him treatment with lactulose and Xifaxan, and suddenly the patient starts talking to you again. And he is back to his baseline. So it's almost like a reversible Alzheimer's disease, right? And it's almost like a miracle when those patients come back. And when this occurs, also, we have to look for other inciting factors, right? What led to this? And many times it's infections, septicemias, could have a pneumonia, could be having a GI bleeding, right? And all that blood in the small bowel is being metabolized into ammonia too. And all that increases the rates of hepatic encephalopathy. So lactulose is a poorly absorbable disaccharide, changes the pH in the colon, decreasing the absorption of ammonia. And Xifaxan is a non-absorbable antibiotic that changes the flora also in the colon to prevent the release of ammonia into the bloodstream and the portal system. So in summary, all patients with cirrhosis should be referred to a liver specialist. Yeah. A little advertisement there. And it is very important that when patients start decompensating, so when we talk about that spectrum, you start thinking about liver transplant immediately, right? Is this patient a transplant candidate? Because unfortunately, that's the only treatment that we have. We don't have right now good antifibrotic agents to try to reverse liver disease. And importantly is what you've heard about today, which has to do with hepatitis C treatment. We know that if we obtain an SBR in patients, their cirrhosis gets better. So their decompensation time, there is less decompensation of liver disease. There is decreased rates of hepatocellular cancer, which is a very important endpoint, right? And our idea is that by curing cirrhosis, we will delay liver transplant. We don't know that for sure, but as you see these new pills that Eric was talking about, they are non-interferon now. So now it's opening a whole new era where we're going to be able to treat those decompensated patients that we couldn't treat with interferon in the past, and it will be very interesting to see what's going to happen with them. Are we going to really reverse their natural history? We don't know that yet because the trials that have been done have been very small. And I was involved in Denver in those trials, and believe me, it was painful for the patients and for me to see them suffer through those treatments and then really don't get much in return because most of them didn't get cured and they got multiple complications such as bleeding and infections. So we're going now, changing gears. We're going to our second lecture. And here we'll be talking about cirrhosis and liver cancer and the need for liver transplantation. So liver cancer is a theme very close to my heart, and that's what I've dedicated a lot in the last few years. We'll talk about the epidemiology all the way to treatment, as in the prior lecture. So this is the main message I want to leave you with, and that is that a patient that has cirrhosis is automatically at risk for liver cancer, right? So if you see a cirrhotic patient, in your mind, he has a pre-malignant lesion, right? Cirrhosis is pre-malignant. Is where we see over 90% of the cancers occur. So a cirrhotic patient has to be surveilled with an ultrasound or an alpha-fetoprotein, whatever you want to use. We'll talk about that in a little while. But we have to be looking for liver cancer every 6 months like clockwork, because that's what's going to come and bite us. And we'll be talking about why. So liver cancer appears in the setting of cirrhosis, and cirrhosis can be from any cause. So you can have cirrhosis from Hep C, Hep B, alcohol, aflatoxin, autoimmune hepatitis. All those insults result in cirrhosis, and from there, we develop hyperplastic nodules, then dysplastic nodules, and then liver cancer, which might be all the way from well to moderate to poorly differentiated, and they have different prognosis according to the level of the differentiation. This is an extract of the SIRS database that looked at what was the estimated number of cases of liver and intrahepatic bile duct. They clumped them together. And as you can see, in 2003, we estimate to have 30,000 cases. But look at this number, 21,000 deaths. This is a highly deadly cancer. About 70% of patients with liver cancer and IHC will die. That means that we're not doing a good job, right? We're not doing a good job detecting them early. And as you can see, the number of new cases are increasing, and therefore, so is the death rate. And look at this horrible numbers. 16.1% of patients with liver cancer will be alive in 5 years. Only 16%. And this gives you an idea of the breakout of all cancers and where liver cancer stays. So we're about in 13, but again, 30,000 and 21,000 deaths. The only one that comes close to that is lung cancer. And still, lung cancer doesn't achieve the same rate of mortality as liver cancer. So there's a lot of work that we have to do with liver cancer. So again, this graph is to show you that because we're having more cirrhosis, as the first slide that I showed you before, we are also having a higher rate of liver cancers. And nowadays in the United States, it's about 3 to 5% per year. So what are the causes, the main causes for liver cancer? Still, hepatitis C is the #1 cause in the United States for liver cancers and for liver transplantation, because they both go together. In the world, hepatitis B has a more predominant role in the development of hepatoma, and that is because of the much higher numbers and worldwide distribution of hepatitis B. So in the US, we suspect there's about 5 million Americans infected with hepatitis C, and you've seen those numbers from Eric before. And hepatitis B in the United States, the prevalence is about 1.2 million, so less than hepatitis C. But the distribution is much different, and you can see, as Fred was alluding to, Asia is a big focus of hepatitis B. Africa is a big focus too. So a lot of work to be done here, and a lot of liver cancer rates, higher cancer rates in these areas. Most of the studies on liver cancer surveillance actually have come from China, and that's the only one study that we have that will support the surveillance of liver cancer. So, as you know, and you've seen before, the epidemiology of hepatitis C infection is that it will lead to cirrhosis in a long time, like 20 to 25 years, and eventually, about 1 to 3% per year will develop hepatoma. So, surveillance of hepatoma, and this is really one of the second key points, right? So remember, cirrhosis is pre-malignant, right? You will grow a cancer in a cirrhotic liver. So you have to look for it. How do we look for it? So this is the second one. Cirrhosis equals surveillance, right? So we have to look for it. Surveillance is just a systematic look for liver cancer. That in liver disease means doing at least an ultrasound every 6 months. And we have different guidelines for that. But essentially, who is that brings us to the question of who is at risk for liver cancer? And again, hepatitis C, hepatitis B are the main culprits. And AASLD has developed different population cohorts that are at different rates of risk for liver cancer. And that's why we have Asians here that if they're a male and are age 40, this is their risk for cancer. So they should be surveilled for cancer a little bit early. Also, those who don't have cirrhosis and have hepatitis B may develop liver cancer. And that's one of the few exceptions to the first rule that I gave you. But that's why you need a liver doctor, huh? And what is the main problem with liver cancer? The main problem has been that it's a tragedy. Look at these numbers. It's more than 75% of patients have advanced liver cancer at diagnosis. More than 3/4 of the patients that we detect with a liver cancer have a cancer too big for us to do anything about. And look at this other number. Less than 20% with HCC had regular surveillance. Less than 20%. So they have a big cancer. We ask them, well, was your doctor looking for cancer prior? Were you having like ultrasounds every 6 months or an alpha-fetoprotein together with an alpha-fetoprotein? Less than 20%. So that's why I told you at the beginning, who's doing primary care? Because we as liver doctors, I don't get this opportunity too often, right, to talk to primary care. Because primary care is at the front of this, right? At detecting cirrhosis and at starting and making sure patients are referred to a liver specialist, or at least they should be getting the standard of care, which will be looking at for cancer every 6 months. And this table tells you that if we get liver cancer early, localized, survival at 1 year is 83%. If we get it late, then 30%, or less if they don't get treatment. So dramatic changes if we get them early. And these are the guidelines. In the Texas Liver Institute, we follow the guideline of doing ultrasound every 6 months and alpha-fetoprotein. And very advanced liver disease, we will also do other imaging studies that are more sensitive. So the diagnosis of a liver nodule. And this is a very complex schema, but essentially what it's telling you is that if a lesion is small, then we can keep looking and do more imaging for looking for growth and looking for other characteristics of that will tip us that this may be a growing cancer and not only like a hyperplastic nodule in the liver or an FNH or another type of benign liver lesion or a hemangioma. On the other hand, if we have a higher than 1 centimeter lesion, then we start looking harder with CT scans and MRIs, and depending on the imaging characteristics, this is one of the major differences between liver cancer and other cancers, right? Because liver cancer, we can make a diagnosis just based on imaging studies. We don't always need a liver biopsy. Actually, most of the time, we don't do a liver biopsy. We actually transplant patients without having a liver biopsy diagnosis of liver cancer, right? Because imaging is so good. We have very defined criteria for imaging, such as arterial enhancement, portovenous washout, growth criteria, that with more than 90% certainty, we can say this is a liver cancer. And just based on that imaging study, we're going to list that patient and we're going to give them extra MELD points too. Therefore, in this region, someone with a hepatoma that qualifies for extra MELD points that are increased every 3 months will be transplanted in about 9 months. So imagine how important and how sure we are that we can make a diagnosis without tissue. Many oncologists don't buy this, right? And they still want to treat it as if it was a breast cancer or lymphoma or some other cancer. Give me tissue, right? Liver cancer is different. We don't need tissue. And that's why we don't always need an oncologist to deal with this disease, because this is a liver disease, right? And that's a mentality that we have to change in our community. When we find a liver cancer, the first thing you have to think is this patient transplantable? And who's going to give you that answer? A liver doctor, right? And a transplant center, right? So these are patients that should be going to the Texas Liver Institute, to one of the transplant centers in the city, right? That's where these patients are really well managed. And so just to touch a little bit on liver transplantation, when we have, these are the criteria of liver transplant. These are the so-called Milan criteria. And if we have one, we may have one lesion that is less than 5 centimeters or 3 lesions, none of them greater than 3 centimeters. If somebody qualifies with this and has the appropriate imaging characteristics, then we can list them for liver transplant with MELD points, right? So extra MELD points, that's the key, right? Because we can list anyone for liver transplant, right? But we want to do it in a way that if we go for liver transplant, the chances of that liver cancer recurring in the new allograft will be low, right? We don't want to transplant someone and then have a recurrence of the cancer in the new liver, right? And that is why we are so selective using the Milan criteria so that the recurrence rate is kept very low, right? And this is actually very good. This was shown in a New England journal with only about 70, 80 patients, and it has proven the pass of time, or the test of time, because it's shown that really it stands up as a good way of selecting patients for liver transplantation. So treatment. For treatment, we use this complicated algorithm also, the Barcelona protocol. But essentially what this is telling us is that early disease cancers, you can treat with either cutting them out, do a liver transplant, or do some kind of treatment, just burning them, do a chemoembolization, a radioembolization, while you take them to liver transplant if they are a candidate. In my mind, and in hepatologist's mind, liver transplantation is the only cure for liver cancer. That's why it's so important when you see liver cancer, first thing in your mind should be, is this a liver transplant candidate? Why is it a cure? Because it's the only modality that will take care of cirrhosis. We can cut it out, but we're leaving a liver that is still cirrhotic. So more cancers will grow in that liver. We can burn it, we can embolize it, but still cirrhosis is there. So liver transplant is curative for liver cancer. The only FDA-approved treatment that we have for liver cancer is sorafenib. So sorafenib is a pill that we can give. It inhibits angiogenesis, right? These tumors grow by growing vessels, right? So that's blocked by sorafenib. And actually in the Texas Liver Institute, we have now a new protocol with a medication for those patients that have failed sorafenib. Although sorafenib, a tyrosine kinase inhibitor, is still a weak drug, and the gain in the studies was only of about 2 to 3 months of survival. So usually if you don't treat hepatoma, most patients will be dead in about 7 to 8 months. So sorafenib, people survive about 10 months, 9 to 10 months. So although it was small, it was statistically significant. And we can go into the details of it and speak like for 2 more hours, but, but we won't. But I want to leave you with this message. Liver cancers should be treated in a multidisciplinary approach, right? In which there is a tumor board. Tumor boards that have hepatologists, oncologists, radiologists, pathologists, transplant surgeons, all of them looking at these images, right? We're all looking at them. We're all in accordance that that is the right diagnosis, that this is the right patient, that the level of liver disease is such and such. And with putting all that into the equation, then we will make a recommendation for that patient either to receive one of the treatment modalities that we said, or to go for liver transplantation, or to have all of them at the same time and in what combination. Plus, we're going to follow that patient. So that patient is taken off your shoulders, which is very important. You don't want any of these patients falling off the cracks, right? So liver tumor boards are very organized boards that have their own coordinators, and they are in San Antonio. There's 2 big tumor boards in the liver transplant centers. So we meet and we talk about those cases and we decide what approach is the best for them. So in conclusion, remember, you see cirrhosis, you think about liver cancer. You see cirrhosis, you think about surveillance for liver cancer. At least an ultrasound every 6 months. In our mind, ultrasound and alpha-fetoprotein because of the trends in alpha-fetoprotein have shown to be better than one alpha-fetoprotein at a time, we do go with ultrasound and alpha-fetoprotein every 6 months at the Texas Liver Institute. And remember, some screening is better than no screening. And remember, many patients, less than 20%, right, were having any kind of surveillance. So remember, cirrhosis equals risk for liver cancer, which equals you have to be looking for it every 6 months. Think liver transplantation. When you see liver cancer, think, is this patient a potential liver transplant candidate? And leave that to the hepatologists, to the liver tumor boards, to the transplant centers to decide that. Because multidisciplinary approaches have shown to improve survival in these patients. Thank you.
Thank you, Dr. Membrania, for that very informative talk. Next, we have Veronica Trevino Garcia, who will be talking about hepatotoxicity, some drugs you know well that can cause liver damage.
So today, I'm going to be discussing drug-induced liver injuries, and we'll be going over 6 features that are important to identifying the likelihood of a drug-induced injury. So what is a drug-induced injury? In short-term, DILI. Well, it's a diagnosis of exclusion and can mimic other liver diseases. So very thorough medical history is important so that we could determine the probability of whether a drug is directly harming the liver versus some other liver disease causing the symptoms. So a few stats. So 2,000 cases of acute liver failure are reported annually. Of those 2,000, 50% of them are related to drug-induced reactions. And 39% of those are related to Tylenol, acetaminophen alone. 13% are idiosyncratic reactions, and usually we'll see a 2 to 5% rate of jaundice patients, which can be a poor prognosis in a patient with a drug reaction. So risk factors that we consider are race. So Hispanic and Black, African American, may be at higher risk for having a reaction to certain medications. We look at age. We look at elderly have a higher risk than a younger patient. When it comes to sex, females are more prone than male. Alcohol intake, a big factor. You've heard already before, alcohol is toxic to the liver. So the more alcohol they consume, the higher at risk they're putting themselves for an interaction with certain medications. So whether they have another liver disease, do they already have hepatitis C or hepatitis B, do they already have cirrhosis? If they already have a liver disease, they are at higher risk for medications then compromising the liver more. And then we look at drug formulations. So is it a long-acting drug or short-acting drug? So the duration, how long does it stay in the body, therefore affecting their symptoms and how their recovery. So with drug reactions, we see 2 types of mechanisms. The first one would be an intrinsic drug reaction in which it's a direct injury to the liver. And this type of reaction is what we see with acetaminophen. Now the recommended dose for Tylenol, 4,000 milligrams in a 24-hour period for a healthy individual who doesn't have liver disease. But in our patients that have liver disease, the recommendation is half of that, so 2 grams per day. And they're not to exceed that to minimize any risk of further injuring their liver. The other type of mechanism would be an idiosyncratic drug reaction, which can either present as a hypersensitivity, in which patients may present with fever, rash, eosinophilia, or a metabolic idiosyncratic reaction. So the 6 features we consider when we're getting a medical history, we'll start with the first one, time of onset. So what were the symptoms that the patient presented with? What do they report? What medications, herbal supplements, over-the-counter drugs have they taken in the past 3 months? Now, typically, with some reactions, you'll see symptoms begin within 24 hours. But sometimes it takes up to 3 months of a patient being on a medication before any symptoms show up. And in the case of amiodarone, sometimes you won't see any type of reaction up to a year that they've been on the medication. So the second thing we look at is the time of recovery. So if we suspect that a drug is causing the problem, we're going to stop it. So usually the symptoms will start resolving, they'll get better, and they usually improve within 1 to 2 weeks of stopping the medication, with full recovery expected in about 2 to 3 months. So it's very important that we document their progression, their recovery progression in their medical history. And then that way we educate the patient too that, what medication they need to stay away from. So injury pattern. There's 3 types of injury patterns that can be identified. So we have a hepatocellular pattern, which will mimic viral hepatitis. So the patient may present with fatigue and weakness. You may note that their ALT and AST are markedly elevated, sometimes 10 times the upper limit of normal. And an example of something that could present this type of pattern is green tea, the use of green tea. Another pattern would be cholestatic, and with that type of pattern, it mimics bile duct obstruction, and patients may present with jaundice, itching, and right upper quadrant pain. With their lab, you might notice in this case their alkaline phosphatase and their GGT are markedly elevated. And examples of medications that can show this pattern or cause this pattern is Augmentin and ciprofloxacin. The third pattern you might see is that the patient may present with both a hepatocellular and a cholestatic symptoms with their reaction. And some of the medicines that cause this mixed pattern are enalapril and sulfonamides. So we know that a drug-induced injury, it's a diagnosis of exclusion. So it's important that we have to rule out that there's no other cause that's bringing about the patient's symptoms. So again, through their history, we want to note their symptoms. We want to note what medications they've taken in the past 3 months. We want to ask them about their risk factors for viral hepatitis, and we want to see how much do they drink. Is it a light drinker, and they don't drink at all, or they're a heavy drinker? And then if they have a prior history of an autoimmune or cardiovascular illness. Some of the labs that you may order to, again, rule out that there's no other cause would be a hepatitis panel, an ANA, liver function test, and an ASMA. And other tests you may consider, considering the patient's presentation, would be an abdominal ultrasound, CT scan, or MRI. So, prior history of a liver injury. So does the drug that you're suspicious of have a history of hurting the liver? So sometimes we don't always know about this. So now we have access to a website called LiverTox website, which is a collection of case studies reporting previous reactions or events from medications causing a drug-induced liver injury. And the other factor we would consider is a response to a re-exposure. So re-challenge or re-exposure. So sometimes, depending on the situation, the medication may be important to that patient's health. So sometimes when you weigh the benefit and the risk, the provider may decide that they want to re-challenge the patient with the medicine. It may be at a lower dose, and then monitor them closely to see if any symptoms reoccur. If they do reoccur, of course, that definitely confirms that the drug is causing a liver injury. But a lot of times we have accidental re-exposures. So in the case with Tylenol, how many times do our patients, try to self-treat and they go to the store and they get all these, they get their cold medicine and their sleep medicine, and then they have chronic pain and they're on, some Vicodin or Norco, and all of these products contain Tylenol, but they don't realize that, so they can easily exceed the recommended dose for Tylenol. So as a resource, the LiverTox website was developed by the National Institute of Diabetes and Digestive and Kidney Disease and the National Library of Medicine. And again, as I mentioned, it's a database full of case studies that's a good resource for us to identify if a drug has a prior history of injuring, causing a liver injury. So in the recent past, what episodes have we heard about? So I don't know if you recall, just recently in October of 2013, there was a product called Oxy Elite Pro that was removed from the market due to the acute hepatitis illness being reported. So there were 56 cases reported, and alone 43 of these cases were in Hawaii. There were 11 hospitalized, 2 liver transplants that were required, and 1 death based on the use of the Oxy Elite Pro. This was an herbal supplement. So again, our concern is a lot of times with herbal supplements, they're marketed as being natural, helpful, and but at the same time, they're not tested thoroughly as our other medications. They're prescription medications, so we don't have any efficient data to show the safety and efficacy of these drugs. In 2000, there was a drug called Rezulin, and that was recalled after being fast-tracked by the FDA for the treatment of diabetes. So this is a example of a medication that did go through the clinical trials. So it went through clinical trial, went through all the phases, phase 3. The data showed benefit for the treatment of diabetes. It was presented to the FDA and was approved. But then once it was approved and began to be used in larger populations, a general population, then the safety information developed, and it resulted in Rezulin being recalled, and it was suspected in 63 deaths. So there's a few other drugs that are very common to us that we use every day, that we need to be mindful about their risk of hurting the liver. So as I mentioned before, we have Tylenol, and usually we see injury to the liver at doses of 7.5 to 10 grams, but we have seen injuries in as little as 4 to 8 gram use. So again, in a patient that has liver disease or that drinks alcohol, we really need to watch their Tylenol intake. They should have less than 2,000 milligrams per day. If we look at amoxicillin or Augmentin have been known to elevate the ALT and AST in some patients, and it presents with a hepatic cholestasis reaction. But this is a very, very small incident, and only about 1 to 3 in 100,000. The other drug we all hear about and know about, statins. So we know that statins, cholesterol medicines, they elevated the ALT and AST usually about 3 times the upper limit of normal. But this is really now, after years and years of being studied, we really see that this only occurs in about 1% of the population. So the concern is that if you know that your patient has liver disease already or drinks regularly, we would monitor their liver function test on a regular basis. Again, as I mentioned, herbs, it's a growing market. We need to be careful of what patients are taking. And it's important when you collect what medications they take that you specify, herbal, over-the-counter, because a lot of times they'll just tell you the prescription meds, but they don't tell you the 20 other herbal supplements they're taking. And the other medication, and the last thing to kind of remember, is recreational drugs. So ecstasy may cause hepatitis and cirrhosis, lead to cirrhosis, and cocaine has been seen to cause elevated LFTs. So a lot of times individuals may not realize that these are hurting their liver, and it may help them to take that first step and consider rehab, if we explain to them what they're doing to their liver. So in conclusion, it's important that we get a thorough history on the patient when they present with symptoms. And we look at the 6 features when considering if an injury is present, and then utilize the LiverTox website to further our knowledge about liver injuries, drug-induced injuries. Thank you.
Thank you, Veronica. And now we have Dr. Fred Porta discussing autoimmune liver disease. How can you spot it if you see it?
Well, hello again. We have to stop meeting like this. So I'm going to run us through quickly 3 diseases that are considered autoimmune in nature. Autoimmune simply means, as you know, that the immune system sees something that is self-antigen as being foreign and tries to attack it. So we'll talk about diagnostic methods, some treatment, and the 3 topics I'll cover are autoimmune hepatitis, primary sclerosing cholangitis, and primary biliary cirrhosis. So autoimmune hepatitis first. This is a disease that's very interesting because the liver gets attacked by the immune system, and we don't quite understand why, what triggers it, but I'll show you some triggers that we found in the environment. It's characterized by the presence of autoantibodies, largely anti-nuclear antibody or smooth muscle antibody. But just to make life a little more interesting, you can have what's called a seronegative autoimmune hepatitis, where these things are all negative, and the person still has autoimmune hepatitis. So I'm going to tell you how to make this diagnosis. Elevation of IgG is very important. That's perhaps the most important single lab test. And then liver biopsy. This is one of those areas where you cannot make the diagnosis without a liver biopsy. If a patient comes to us and they've been told they have autoimmune hepatitis, we ask to look at the biopsy. Oh, I've never been biopsied, doctor. Well, then you don't have autoimmune hepatitis until we biopsy you. That's how important the biopsy is. So 200,000 people or maybe more are afflicted with this, definitely much more common in women. And there's a bimodal age distribution. So we see it in the young, and then we see it in the middle age. Middle age being women in their 60s and 70s. That's right. That's where middle age is nowadays. So when we see it in the young, though, it's very aggressive. By the time we find it when people are in their 50s and 60s, oftentimes they already have cirrhosis, and it comes to light kind of accidentally. And then we realize, wow, you've got burned out autoimmune liver disease. You actually have cirrhosis now. It accounts for only 6% of all the things we transplant. And we've been treating this for my entire career, but what's interesting is in the 1970s, there was no therapy for this, and all of the cases were largely studied by one person, a fellow named Al Chaya at the Mayo Clinic. He collected all these cases, and prior to him sort of teaching us how to treat this condition, most people died within 10 years of the diagnosis. Really amazing. And that was in the 1970s, so it wasn't that long ago. It can present as acute hepatitis, fulminant liver failure, but what's underlined there is how it usually presents, chronic hepatitis with or without cirrhosis. We can see it recur after liver transplant. But guess what? It's no longer autoimmune after transplant because there's no autoantigens left in that liver. It's a foreign liver. So it's an immune hepatitis, but just out of convenience, we call it recurrence of autoimmune hepatitis, but it really isn't. And it can overlap with other cholestatic liver diseases. So here's some drugs, and the one that I've underlined is one I want you to be aware of. A lot of times, a drug will kick off the initial event of autoimmune hepatitis and start the process. So you need a genetic predisposition and then an environmental trigger. And sometimes that environmental trigger is a drug. And one of the more common ones, believe it or not, is nitrofurantoin or macrobid. So a lot of times we'll see an older lady who comes in, was treated with this antibiotic for a bladder infection, and now has autoimmune liver disease. It's very interesting that through molecular mimicry, certain drugs may actually kick off this process of autoimmune liver disease. And then some of the over-the-counter stuff that we talked about earlier that have been known to kick off autoimmune liver disease are listed there as well. So very important to take a drug history when a patient presents with this to see if that was in fact the trigger that started everything off. Like I said, ANA, smooth muscle antibody, liver-kidney microsomal antibody, they may be positive, and oftentimes they are, but in some people they're not, or they're not very impressive. But elevation of the serum IgG is really what you need. So the two things you absolutely need to make the diagnosis, the two most predictive things, elevated serum IgG and a liver biopsy that's compatible with autoimmune hepatitis. Nothing else really matters. So ANA is not that important. This doesn't look like anything to most of you, but to a pathologist, this is a really important view because all those purple dots are inflammatory cells under the microscope in the liver. And what we look for are these inflammatory cells that have now created a loss of the clean demarcation between the portal tract and the liver. This interface is inflamed, so we call this interface hepatitis. It used to be called piecemeal necrosis, but someone decided we need a new name. Piecemeal sounds funny, so we'll opt for a much better name, interface hepatitis. We look for eosinophils, but they may or may not be present. We really look for plasma cells, but you know what? They may not be present. So this is a really complicated thing to diagnose. And if you don't have a well-versed liver pathologist, if you show them chronic hepatitis C or autoimmune hepatitis, they may not be able to tell the difference. So you really need to have a liver pathologist look at something like this because it can be tricky to make this diagnosis. And remember I talked about Wilson's earlier? Well, guess what? Wilson's can mimic a lot of things. So Wilson's, viral hepatitis, all of these things can actually look similar to this, drug-induced hepatitis. So you really need to have several features of autoimmune liver disease on the biopsy to make the diagnosis. If the liver enzymes are greater than 10 times the upper limit of normal, which is 300 or higher, it's a no-brainer, we treat. Or if they're greater than 5 times the upper limit of normal, which is about 150 or so, and the patient has histologic features, we treat them. We don't always treat autoimmune hepatitis. So for example, if the AST and ALT are 80 and the biopsy is very, very mild, then we may not actually start therapy. What is the therapy? It's lifelong immune suppression. So we usually start off with azathioprine and 6-mercaptopurine and prednisone. And the goal is to lower the prednisone down to 0, but we're not always successful. Maybe we can get them down to 10 milligrams or less of prednisone and somewhere between 50 and 150 milligrams of azathioprine. Azathioprine takes a few weeks to kick in, so we count on the prednisone to get rid of the inflammation quickly, and then we leave them on the azathioprine for the rest of their lives. Okay, there's downsides to that, of course, but the downside of not treating autoimmune liver disease is much, much worse. So this is a chronic condition, never really goes away on its own. Primary sclerosing cholangitis. This is another autoimmune condition. Walter Payton, who was a running back for the Chicago Bears, died of this disease. He ultimately got cancer of the bile ducts, cholangiocarcinoma. And I'll show you that's what many of these people eventually die of. But this is a disease that affects the bile ducts inside the liver and sometimes outside of the liver. Much more common in men than it is in women. And here's the interesting pearl here. 80% of the people who get this disease have underlying inflammatory bowel disease. But most people with inflammatory bowel disease will never get primary sclerosing cholangitis. So people that have sclerosing cholangitis often have IBD, but most people with IBD will never get PSC, which means that IBD is much more common than PSC, okay? If left untreated, the median survival is 12 years, but I'll show you the treatment's not very effective. So these folks need to be surveyed. The risk of getting bile duct cancer, which oftentimes, unfortunately, is fatal, is 10 to 30%. They also have a risk of liver cancer, but later on in the course of the disease. And interestingly, because many of them have inflammatory bowel disease, they're at high risk for getting colon cancer as well. So these are three very important cancers that can afflict people with PSC. Now, how do you make the diagnosis? If the alkaline phosphatase is elevated, it needs to be explained, because that is the lab test that's abnormal in PSC. And so many times we'll get patients referred to us and we'll look back and they've got years of abnormal liver enzymes that were ignored, or they were mildly elevated and they were told, well, these enzymes aren't that high. Any abnormality in liver enzymes must be explained. It's never normal to have them. So we look at ERCP or MRCP, and we look for stricturin. What does that look like? On the left here, you'll see a cholangiogram where you see some narrowing of the bile ducts. These are the ducts inside the liver that drain bile acids. They become narrowed, and eventually they can close off. And if they close off, people can become jaundiced, but they can also become very itchy. Bile acids that don't drain make people itch terribly sometimes. If we do a liver biopsy, which is on the far right, we see some classic features, but it might be so subtle that it's missed. So liver biopsy is actually not the main way to make this diagnosis. It's usually ERCP. MRCP, which is MRI cholangiography, is actually not very good, to be honest. Even in the best centers with the best machines, it's a pretty shaky modality. Oftentimes we'll start with that, but to really get good images, we want to get an ERCP. How do we treat it? We put the patients on a drug that has a little bit of controversy for this disease. We put them on a drug called ursodeoxycholic acid. There was a study done at the Mayo Clinic looking at high dose, low dose, and they found that if you give this in high dose, it actually can hurt the patient. So many people got scared and they said, well, we don't want to treat anybody with this condition. In our practice, we tend to treat people with lower dose ursodeoxycholic acid because it does decrease colon cancer risk in those with severe IBD. We also think that it has some positive effects in some patients. We also need to survey patients for cholangiocarcinoma. We usually do that by doing an MRI every year. So this is a very serious disease. Liver transplant can be curative, although some people get a recurrence after transplant, but they certainly need to be followed and watched for cholangiocarcinoma. Primary biliary cirrhosis is a different disease. This condition occurs mainly in women. For every 9 women that get it, 1 man gets this condition. We think it's an autoimmune condition, and it's very interesting for different reasons. There's some genetic clustering of this disease, but it's often associated with autoimmune conditions. Number 1 symptom, fatigue, even before they get cirrhosis. The name is unfortunate because usually we diagnose it before they're cirrhotic, but they're all fatigued and they're all itchy. A lot of pruritus. And they have itchy palms and itchy soles. And the itching is worse at night. They also get osteopenia, and they can get xanthomas. The picture there of these little white plaques around the eyes, those are called xanthomas or xanthelasmas. This is very common in this condition. It can be a genetic condition as well. They don't need to have PBC if they have that, but something to think about. But most people have some other autoimmune condition like thyroid abnormality, dry eyes, dry mouth, which is called Sicca syndrome. They can get Raynaud's phenomenon where their fingers turn purple or white in the cold. They can get the Crest syndrome where they get calcium deposits under their fingertips, what that picture is showing you there. They can get telangiectasia, usually on their face or their chest. So these are very interesting findings that we look for. Esophageal dysmotility, they may have trouble swallowing foods. The antimitochondrial antibody is often positive, so that's the one blood test that 90% of the time will guide us toward this, and their alkaline phosphatase is always elevated when they have this disease. So how do we treat this condition? Well, we do a biopsy. It's absolutely mandatory because sometimes they have autoimmune hepatitis as well, and we have to treat both conditions. We put these folks on URSA. And this is a prognostic score that I just want you to be aware exists, but we don't really use this. It can actually scare the patients because sometimes you plug these numbers in and it says that their mortality is incredibly high, and sometimes it is. But we put them on URSO and we keep them on it for life, and it does work quite well actually. But if it doesn't work and they progress to cirrhosis, this is a great condition to transplant. They do incredibly well after liver transplant, and they rarely get their disease back, and their long-term survival is outstanding. So these autoimmune conditions of the liver are not that uncommon. You need to have a high index of suspicion, meaning if the liver enzymes are elevated, you got to go looking for it. Liver biopsy is mandatory pretty much in all autoimmune liver diseases. This will never be replaced by MR elastography or FibroScan. We need to see the biopsy. And blood tests are also very important. All of these conditions that I went over are treatable. So the key is early diagnosis, okay? I know I ran through that quickly, but I want to keep us on time because we have a lot of other exciting things to discuss, and we'll have time in the Q&A to answer questions if you have any. Thanks for your attention.
Thank you, Dr. Pardat. And our final speaker of the day is, again, Angie Coast, and she will discuss how clinical research works, the good, the bad, and how to avoid the ugly.
So the organizers of conference either don't like me or don't like you guys because I'm back up here again. And I know how we've went over a little bit, and I also am very aware that I'm the one thing between you and lunch. So we'll get through this as quickly as possible, but not in the 10 minutes I had earlier. So objectives just to understand the stages and some types of clinical pharmaceutical research, understand the risks and benefits of research, and the regulatory challenges that we see every day. I've been working in research for many years, and I actually love it, very, very passionate about it. I wanted to just start really quick with a statistic. Actually, Forbes recently did a study, and they were looking at how much it costs pharmaceutical companies to bring drugs to market. And if there's a small company with only one drug in development, it usually costs them about $350 million to even get it to the point where they could possibly sell or get to marketing, just to get it to the point where it'll be FDA approvable. And if there's a company with multiple drugs being developed, it actually will cost them about $5 billion per drug to bring one to market. So I think that's just like phenomenal. And the other really big thing is 95% of drugs that are actually enter clinical trials, they're not shown to be safe and effective. So only about 5% of those that even enter clinical trials, not to mention all the ones that are stopped in the scientific labs, but only about 5% of those will even ever be shown to be useful to us. So we're getting more and more to individualize medicine, which is a good thing, and hopefully save money along the way. And but it's going to be a process. So the benefits of research. One of the biggest things is serving our uninsured and underinsured population. So to me, I say if you don't want to have somebody sitting on the Affordable Care Act website for many, many days, you could probably send them over to Texas Liver Institute, and we could find a way to treat them if they have a liver disease. So that's, to me, one of the biggest thrills I get out of research is serving those that might not have a way to get treatment otherwise, as well as just being in the forefront of all these treatments that even Dr. Lotwitz was talking about this morning. Time flies when you're having fun, right? So what Dr. Lotwitz was talking about this morning, I've been involved in almost all of those trials, and it's very rewarding work. So we got to obtain expert medical care at leading healthcare facilities. Treatments may be more effective. Obviously, we saw that today. The treatments that were given in research have been more effective than what we had out on the market, and just helping others by contributing to further treatment. So one of the kind of downsides is that research is very rigidly structured. In medicine, we want to treat people individually, but in research, we don't have that option. We have very strict procedures that we have to go by, medication schedules. You can't walk into a room as an investigator and have a feeling about whether one treatment's more successful than another. We have to avoid that bias, because if I walk in and I'm kind of like, oh, that's kind of bad what I'm looking at, I'm going to have the patient be afraid and not really want to continue the treatment. But one of the biggest things is treating the patients as a research subject versus a patient. We all think about being, looking at them as a human and treating them like that, when actually we have to kind of treat them like a research subject in some ways. So research is just definitely different than general medical practice. Documentation is one of the biggest things. We kind of learn in medicine, if you don't write it down, it's not done, but we avoid double documentation. In research, we usually have at least triple documentation because we have to have this stuff well documented because eventually it's going to be audited, it's going to be under a lot of scrutiny to get these drugs to market. So all trial data, reportable, and it's to be reviewed by the sponsors and the health authorities, which in this case is the FDA. So again, treatment regimens are subject assigned to receive drugs or devices in a specific protocol, but again, it's all experimental. It may involve unproven drugs. It often involves unproven drugs, and we have to strictly follow those guidelines. Some subjects, of course, will receive no treatment at all. That's always one of the biggest questions we get is there going to be a placebo? If there's an acceptable a standard of care treatment out on the market, then obviously the studies usually aren't placebo-controlled. Earlier, Teresa was talking about NASH. That's one that we really don't have an approved treatment for, so our studies for NASH right now are usually placebo-controlled. So that's just something that you have to be very upfront about the patient with in the beginning. Again, we have to avoid bias multiple ways, whether it be randomization of a subject to a specific study arm, and of course, avoiding bias on our part. Blinding is a procedure which one or more parties in the trial, it's usually what we call double blind, which I don't know what the patient's getting, the patient doesn't know what they're getting as well, just so that we, again, avoid that bias. Randomization is just like flipping a coin. I tell the patients that's what happens. We don't know what arm you're going to get into until you come in the clinic to start. It's usually computer generated. Just a little bit of, I'm kind of getting into the ugly part now, avoiding the ugly in this research. So I wanted to touch on the why there's some bias out there in the world about research. I mean, you can kind of understand when you look through some of this stuff why some patients are very fearful of research. How we need to overcome that. So from 1939 to 1945, the Nazis did a lot of stuff in clinical trials that, of course, they were in the prison camps, and the doctors would go in and just do horrendous things to people. They wanted to study hypothermia, so they'd put people in ice baths for hours just to see how they responded to it. They did studies on 1,500 sets of twins because they wanted to make people's DNA more alike, and so they would actually even suture these kids together. They would take off their arms and study the DNA in there. And so out of 1,500 sets of twins, there was only about 200 survivals. There's one picture here with the legs, with the legs back there. It was basically they wanted to look at transplantation. They wanted to see if they could transplant bones, so they just started cutting people's legs off, no anesthesia, and then try to implant it to another person. So obviously, a lot of bad things happened there. But what happened out of all that after the trials was we came up with the Nuremberg Code. So basically, these are new code that we have to follow it's part of the GCP, what we call good clinical practice. So the patient has to volunteer, consent is essential, we have to inform them of everything, their risks and benefits, other treatments that may be available, and the big thing is that if they decide at any point in time to withdraw from treatment, they can. And if we find out in midway through a study that it's not working, we have to be ready to stop that study to protect the people. The Tuskegee trials took place here in America. That was another thing that really hurt us from a research perspective. It went on for 40 years. So basically, they took poor African-American men in the South, and the government told them that they were going to be getting free care and doctor visits and things like that, but they didn't tell them that they had syphilis. So a large number of them had syphilis, over 300 of them had syphilis, and they weren't given treatment, and they weren't told they had it. So what happened was they started spreading it. And actually, the doctors were actually interested in studying sexuality amongst the men in the community, so that's how they did it. It was weird to them, how they could spread this so readily. And then basically there was a person who reported they knew what was going on, and so in 1972 it got released to the press. And then, of course, a lot of people died. Kids were born to infected women. A lot of wives got infected just because they didn't know they had it. Not to mention that penicillin was brought out in 1942, actually, so they knew through most of this trial that penicillin would have cured these people, and they didn't offer it to them. So out of that developed actually the Office of Human Research Protection and the Code of Federal Regulations. So the Department of Health and Human Services got involved and after this came about. And now this is kind of what still guides us today in a lot of our research. So the National Commission made up the Belmont Report, which is ethical principles and guidelines for human research. So we always talk about respect. So we have to offer protections to anybody who's doing research. Beneficence is do no harm. We all know what that is. So, of course, going into a study, if we think it's going to be harmful, we can't go forward with that. And again, stopping it if we decide that it is going to be harmful or less effective than a known treatment. And then to just treat individuals and groups fairly. So again, the good clinical practice. We have what's called International Conference on Harmonization. We always say ICH GCP guidelines. These are guidelines that we go about in research just to keep everything just standardized, basically. So the informed consent. So a lot of people have seen an informed consent form, but this is actually a process. So we've got studies that every time the patient comes in, there might be a new consent form, because as everything starts to develop, as we're doing research, we have to inform the current subjects who are on the study about what's going on. So for instance, recently, when sofosbuvir was approved in December, we actually have went back now, and all of our subjects who are taking that drug, we have to tell them what are their alternatives to research, right? So we've had to go back and inform all them, actually this drug's on the market now, so if you wanted to come out of a study, you could. Most of them are not going to do that, but that's still part of our obligation to them, to let them know what else is available out there. So the informed consent, initially we do it before we start any type of study procedures, but we just need to know that this is ongoing all the time. So I can't divulge all data to patients, but of course if anything new comes out, if adverse events have happened, if somebody's died, anything like that, the patients have to be informed about. So some of the things that have caused negative community views on research, even besides this, there was a very interesting play, if anybody gets to see it, about, it was called Wit. And it was actually about a professor who, she had end-stage ovarian cancer, and she went into a trial because she knew she didn't have much other option. So she went into a trial, and in the beginning, she was very interested in how they were treating her. She was interested in science as well. And then she quickly realized that, you know, it's a lot more important to have kindness over intellect. So it was very interesting. So you need to treat the research people as human and not as a data point. So many patients believe they may get a placebo. One of the things that I wanted to say to everybody here about how long we've been working with hepatitis C is back in the day when we would treat people with interferon-based therapies, and we would always say, like, hepatitis C is an insidious illness. It doesn't really have a lot of symptoms. Patients might complain of fatigue, and we'd say, well, 80% of people in America are fatigued, right? So it's probably not your hepatitis. Or maybe even tell people, what if I get rid of your hepatitis and you're still fatigued? Obviously, something else is wrong. So one of the biggest things to me in the all-oral therapies is actually to see how not insidious hepatitis C really is. So these patients will come in and actually tell you that they feel better than they felt in 20 years. They have more energy. So before, we're treating them with the medicine, making them sick, right? So we didn't get to see that, but now it's very, very obvious to me. So I'm much more aware of that when I'm actually just doing basic hepatitis teaching now. So some of the challenges, recruiting, we always we have a referral department in place. We have a recruiting department in place. We get a lot of referrals from the outside. Again, a lot of patients that can't afford therapy or they're not candidates for some therapy, but they may be inside of a research study. Earlier we mentioned about, we actually have a study that's starting that's going to be treating pre- and post-transplant patients. So there's nothing out for those people, but golly, wouldn't we like to get these people negative before they go into transplant, right? So that's a big goal, then they don't reinfect their new liver. So those are things that they wouldn't have access to on the outside. Retention is a big thing. A lot of studies, especially when you're studying, survival rates and stuff, the patients just tend to move and go other places, and they don't necessarily follow through. So in the beginning, it's really an obligation from us to look at these patients and talk to them about where they are in their life. Are they planning to change jobs? Do they have family around? And how likely they are to complete the study. And again, Dr. Lotwitz talked about earlier, we saw how tight these numbers are amongst the companies and how competitive it is. So if I have 2 people fall out of a trial with 100 patients, it's really bad. It could really make a difference in what these numbers end up looking like. So we have to be really careful when we pick people early on. Adverse events. So I always think it's funny about when people read all of the package inserts. So, you may be more likely to be hit by a bus or something when you're taking Tylenol, I don't know. But when the patients come in, everything that they report to us, if it's not in their past medical history, we have to discuss it with them and decide if we're going to report it as an adverse event. And so these adverse events are then looked at statistically across the world and how many times, they're going to end up in the package insert. So maybe 2 people got run over by the bus in the world, and then that's going to go in the package insert. So I always tell people to be really careful when they're reading those package inserts. Doesn't necessarily mean it's going to happen to you, but doesn't mean it's not going to happen to you. Bottom line with research, there's always a statement in all informed consents that says there's risks that we may not know about, and that's what I always tell them. If somebody doesn't tell you that, they're lying. Serious adverse events are a little bit, you'll see this in data, how many SAEs were they, occurred on a trial. So basically this is things, the most important thing here is of course if somebody died, but also if they required a hospitalization during the trial, we have to report all this. We have to be very quick to follow up. It's very important when the sponsor of the trial, the pharmaceutical company, is reporting back to the FDA, they have very strict guidelines that they have to go with, so we have to get them information very quickly about these patients. So if they need to inform all the other trial sites in the world doing this study, hey, we got a patient up here with heart failure, or hey, somebody died, and hey, we need to inform all these other patients, we need to stop the trial, whatever. So very critical there. Many stakeholders here. The PI is ultimately the responsible person. That's the person that's going to end up in orange scrubs if somebody's falsifying data, right? They're going to end up in a federal prison somewhere. But that's the person who's ultimately responsible for everything. But then, we're considered sub-investigators there, and we're seeing the patients every day. We have to follow them up really closely. The coordinators, we have many coordinators at our center. These are the people that see the patients on a daily basis. They help us with consenting. They get the phone calls from the patients. So, of course, there's big stakeholders in making sure that these patients get treated and get cured. The sponsor of the study is often the pharmaceutical company, the academic institute, the NIH, those people. The monitor is actually the person who comes from the sponsor to our site to make sure that we're not falsifying data and making stuff up and that we're treating the people appropriately. So, of course, they have an obligation back to the sponsor. The IRB is the Institutional Review Board. So that's basically just an independent group of people who are in place for the patient's safety. So we may say, oh, wow, I'd love to do this study. Dr. Porter-Lotwitz tells me, hey, let's do this. Well, we have to go through an IRB when we're going to do something that is affecting the patients in any way, because they look at it from a patient standpoint. They make sure that we explain things from a patient's perspective. Is it at a 5th grade level, a 6th grade level, whatever. So those people are there, and they also are just big. It's for safety oversight, basically. And, of course, the FDA is a big stakeholder in all this, because they're going to be the ones ultimately responsible for making decisions to bring these drugs to market, where multiple people will be, they'll be available to them. Veronica touched early on drugs that have come to market, and then we find that they're not successful, or they may be more harmful than good. One thing that a lot of you in the room may know about is, telaprevir. There were some things that happened that we didn't really pick up on in clinical trials. And then all of a sudden people are at different meetings talking about, somebody's got their butts hurting and their butts burning and they're having bad diarrhea. And everybody starts to put this all together, and might have thought it was hemorrhoids in the beginning, and everybody puts it together. Oh, I think that could be a problem now. So then that came about. So it's kind of interesting how we end up doing that when more and more people get treated with the medicine. We start to see those things. And, of course, the subject. The subject is the patient. So that's the number one person to me that is a stakeholder in research. I can't tell you how many times I've said to a patient, well, you may only have 10% chance at this point if you're net negative, and they'll tell me that, you know, I could be that 10%. I could be that 1 out of 10 that made it. So they're ultimately the subject and the sponsor are the ones that we're the most obligated. I mean, the subject and the family are the ones we're most obligated to. Thank you. Oh, this is just showing you really quickly how we get through studies. Preclinical, phase 1, phase 2, phase 3, phase 4. Phase 4 is post-marketing. A lot of the stuff that we do that are treatment related, those are phase 2, phase 3. On average, about 250 show significant promise for drugs when they get to this to be further evaluated. So I just wanted to touch with you a little bit about basically phase 1 is picking up safety data. We don't necessarily expect these patients to get cured. It's looking for drug-drug interactions. Phase 2 and 3 are actually treatment studies. Phase 2 a lot more safety-oriented, maybe dose-oriented, trying to find the right dose of a drug. And then by phase 3, we're actually treating thousands of patients at that point because we've already got our earlier data. And then phase 4, the FDA will often tell companies, you're obligated to give me more data on this after it's come to market. So that's it. Thank you.
Thank you, Angie. At this time, we have the speakers from the recent sessions available to answer your questions. Also, as a reminder, if you have not signed in, please do so at the registration desk, as this will be the way you can get your CME and CNE credits. Okay, do we have any questions?
We have one right here.
Thank you. Okay.
I had one question for the doctor about you both. Well, both of you have been speaking about inflammation as a symptom throughout a lot of these disease processes, and I agree with you about herbals and over-the-counter. I mean, heroin's natural too. That doesn't mean it doesn't cause harm. What about anti-inflammatories such as the omega-3, omega-6, the prescription of Lovaza? That's a medicine that's come out as far as an anti-inflammatory for that.
Yeah, I'll address that. So yes, there are some emerging data on things that ameliorate inflammatory processes, and I think there's probably a lot of value to exploring these things because we do know that inflammation leads to fibrosis, it leads to symptomatic problems. So Lovaza, as well as other things, are now being systematically studied, and I think what we really need are very rigorous clinical trials to assess these things so that we have good data like we do in other facets of treatment. So stay tuned. I think people are now aware that inflammation is a big deal, causes a lot of ill effects in the body, and I think over the next 10 years we're going to see a lot of research in that area.
My question is for the hepatologist. Do you all take new referrals, new patients, and how long is the wait?
We're seeing patients right after this, so very short. Yes, no, we're happy to obviously take referrals. We see the Texas Liver Institute as a major resource. It's a one-of-a-kind facility that just deals with liver disease only. And we like to try and get people in within 2 or 3 weeks. And for urgent issues, you know, Dr. Mambrino heads up our liver cancer division, but for major urgent issues, we can see the patients usually that week. So it's simply a matter of calling us, and if there's an urgent problem, we're happy to accommodate.
Yeah, we're always reviewing urgent consults, particularly if someone has liver cancer, liver decompensation. I mean, there's a thought on liver transplantation, had a recent hospitalization. We always review that pretty thoroughly and get them, as Fred says, almost within a week.
And is this only for adults? Is this like 18 and above, or what do you consider your age group?
Yeah, we are an adult. We don't have a pediatric hepatologist, but having said that, all of us have seen young adults or older children, ages 15, 16, and beyond. So if you have a case like that, we're happy to discuss it, but we don't have a formally trained pediatric hepatologist that would see one of the smaller ones.
And that's a major issue also in the transplant centers many times, that there's no great availability of a transplant pediatric hepatologist. So yeah, I think all of us have some experience with the children that look like adults.
What should we tell our patients to expect if they get enrolled into a clinical trial? Are they seen weekly and it's several hours each week, or are they able to hold jobs and keep up with the trial?
So we always see, Veronica and I see most of the research patients. They usually get consulted by either one of the doctors or by outside referral, one of the clinicians, and get referred over to us. So every study is different. I have a study starting now that, we see them once every 6 months for 3 years. It's like a registry study. And other studies, they have to come in every week. So the biggest thing is that they just have to be able to do that. A lot of the studies compensate for their travel. And there's times as well that, we may have to dose reduce or whatever, and we may have to see them even more often than the trial specifies. So the big thing about side effects, of course, we can't tell you anything like that, right? I did tell you that it's pretty amazing for me how many people have told me with some of the newer hepatitis C therapy that they feel better than they have in many years. They feel a lot of energy. So, but when it comes to other studies, it's just all written out in the informed consent about what possibly could happen. Some of our NASH studies, of course, are a lot different. We still have infusion studies and things like that. It's a lot newer. Anti-inflammatory stuff, so those will be different than some of the hepatitis C trials. But yeah, we have a referral department.
I think yours is a tax question. Can they continue to work and pay taxes?
Oh, yeah,
yes, they can. So no, this is, obviously we want to accommodate people's normal lives and daily routine. So absolutely they continue to work, and we can work around their schedules a great deal of the time. So yeah, it's not particularly onerous on their schedule.
And when they come in to consider enrolling in a study, we go over, as part of the, as Angie mentioned, the informed consent. I mean, it specifies on the informed consent exactly what the timeline is and how often, they have to come in, so that we can ensure that, they can make that commitment and they're aware of what that commitment is for that study. Because, we've had studies in the past where they had to come in like every day for the first month. And that's taxing, but I mean, if they're able to do it and they're willing to do it, they came in, they enrolled in the study. And sometimes for work, then if they're not able to do that rigorous study, then, we got to find something different that's more work friendly, with their schedule, patient friendly with their schedule.
So we have a question here. Should a patient with cirrhosis take NSAIDs? Why or why not? And what about antifungal medications like fluconazole?
Yeah, NSAIDs and cirrhotics is one of our pearls of things that we want to avoid. And in cirrhotic patients, NSAIDs, we avoid them for two main reasons. One is it increases the frequency of ulcers, right? So cirrhotics have portal hypertensive gastropathy, and they have coagulopathy. They're prone to bleeding, right? So you give an NSAID, they get an ulcer, they get a bleed, not a good thing. And secondary, also, prostaglandins helps us keep perfusion to the kidneys, right? So if you give an NSAID, then you are compromising perfusion to kidneys, leading to kidney failure. And as you saw in the slides, kidney failure and cirrhosis, bad combination, high mortality.
Elevated liver enzymes. Is IgG part of your initial screen versus ANA, ASMA for autoimmune hepatitis?
If we're suspecting autoimmune hepatitis, yes, serum immune globulins are a must. So quantitative immune globulins will give you IgM, IgA, and IgG, and really IgG is the one you're interested in, although in PBC, IgM is elevated. So we don't routinely do that on every patient that walks in the door, but when we're trying to decipher why liver enzymes are elevated, it should be part of your primary workup. And I don't think we answered the question about fluconazole. Fluconazole can obviously be given, and we often use it in patients with advanced liver disease. It can cause a cholestatic hepatitis, but patients with cirrhosis are no more prone to that than people without cirrhosis. And I think Dr. Membranio brings up a good point about the problems with non-cirrhoticals, but remember, cirrhosis is a grade. It's not black and white. It's early cirrhosis, advanced cirrhosis, and everything in between. And for the very early cirrhotic, oftentimes they're taking NSAIDs. No one knows that they even have cirrhosis. We try and avoid NSAIDs and things in very advanced late-stage disease.
One point also is that cirrhosis, it's amazing to me how the liver, even though it's significantly harmed, still can metabolize most of the drugs that we can throw at it. So it's amazing that we, even before liver transplants, I mean, we are able to get away with treating patients with almost every drug, right, that they need at that point. It's only depending on each case, right, we start withdrawing some drugs, but still the liver maintains that detoxifying capacity until the very end.
So we also have another question. Is there a criteria being followed for a patient with refractory ascites and getting paracentesis weekly, not considered a good candidate for TIPS procedure?
Yeah, refractory ascites is certainly an alternative, and the problem comes in that both refractory ascites and TIPS, paracentesis and TIPS, don't improve mortality. Right, so this has been investigated very thoroughly, particularly in the setting of TIPS. So we view them just as a bridge towards liver transplantation.
If a patient has cirrhosis and is cured of their hepatitis C, will their liver regenerate and the cirrhosis go away?
That's a great question. I wish I knew the answer. So as we were saying, cirrhosis is a big spectrum, right? We think that there is a point of no return within cirrhosis, particularly in the decompensated state. In the compensated state is when we have seen by the studies that have biopsied these patients like pre and post hepatitis C eradication, or in patients who have undergone bypass for NASH, right? And there has been regression of the fatty liver disease and the scar tissue. So yes, the belief is that there is a point where cirrhosis is reversible. Where that point lies exactly, I cannot tell you, but by clinical grounds, we think that those are the early cirrhotics.
How many patients with autoimmune hepatitis end up getting liver transplants?
The minority. So if we don't diagnose it early and they present to us as very late stage, they can certainly end up with a transplant, or if they present with fulminant liver failure. But by and large, if we diagnose it in a timely fashion, we treat it, we can prevent progression of the liver disease. And this is one disease where I've seen patients regress and go from moderate fibrosis down to no fibrosis after a few years of therapy. So we know the liver is a very dynamic organ. It lays down collagen, it picks up collagen, and so with treatment, we do expect improvement. So fortunately, it only makes up 6% of all the transplants we do, and that's largely because if it's diagnosed, it's very treatable.
So overall in the nation, I mean, at any one time in the list, there's about 16,000 people, 15,000 people on the list, and of those, we transplant about 4,000 to 5,000. So you can make the math there. So a lot of patients still will not get transplanted, but also as Fred says, I mean, we're getting better at selection, right? So not everybody who is on the transplant list is an imminent need for liver transplantation, and we're trying to concentrate on the low-hanging fruit, right, which is the patients that are at imminent risk of death, which is what the MEL score tries to predict. It's not a perfect tool. and in some diseases such as PSC and PBC, it defavors the disease progression score, does not reflect the real clinical disease. But it's certainly a tool that has proven to be effective over the last more than decade.
Can patients with liver disease take Tylenol?
So yes, they can take Tylenol as long as they don't exceed 2,000 milligrams in a 24-hour period. That's what the recommended dose for an individual with liver disease. So again, they need to be careful with all the multiple agents that they may take for pain, for cold, for sleep. You know, they need to learn how to read the labels. And what we usually tell patients is their Tylenol would be Tylenol 325 milligram, their regular strength, and they can take up to 6 tablets in a 24-hour period. That would be their 2,000 per day max. If they drink alcohol, I'd have to say we'd have to be careful with the Tylenol, because as we know, Tylenol and alcohol do not mix. So make sure that they're not heavy drinkers.
This one is for Dr. Membranio. AFP seems to be controversial now. Can you explain why and why you choose to continue to order it? And also, does the Texas Liver Institute perform living liver donor transplant? If not, why?
Yeah, those are great questions. AFP has been an ongoing discussion in the hepatology world, and you saw the diversion in the guidelines. Essentially, the reason is that AFP is a lousy test, right? So we can miss about 40% of hepatomas, right? And so is the case, like, let's say, PSA, right? Also is a lousy marker. The issue is that we have data that probably an AFP at one point is not as good as a trend in AFP, right? So that has not been evaluated. So that's one of the arguments of why we continue to follow it. We feel that a trend of AFP is very predictive of liver cancer and is useful. The other argument is that, remember that these people, the patients with cirrhosis, are not being screened in the community. I mean, they're getting nothing, right? And if we take out one easy test, that trying to make it easy for someone to just order at least one test, I think that one is better than none, right? We can discuss all day about sensitivity, specificity, but at the end of the day, when you're in front of the patient, right, I don't see that taking out a cheap test that can potentially be easy to order in a patient should be our approach here, when we are seeing the data clearly that we are not even doing the basics on these patients.
Thank you. That concludes our panel discussions. We ran out of time. We have a lot of good questions left, but we can post it on our website, so look for it on our website at www.txliver.com.
Before you break for lunch, we're going to have a couple of concluding remarks by Veronica, but I want to make a couple of my own. It took quite a bit to put this meeting on. I hope you enjoyed it. We aim to do this every year, so thank you. A special thank you to Teresa and Veronica, who worked very hard to put this on in front of you, but behind the scenes there's a few people who need to be mentioned: Mary Knox, Christy Brown, Millie Bradley, Brian Stoffel, Johnny Griffin, and Lisa Petticone. All of them worked very hard to actually put this on. It's a lot more work than it may appear to put one of these things on, and we're very happy that we can bring you these educational things. The other thing I want to tell you before I turn this back over to Teresa and Veronica is that the program's not over. There's a non-CME Gilead-sponsored lecture on hepatitis C, and that's going to be presented by Corinne Wentworth, who's a PA from Baylor University Medical Center in Dallas, and previously she was at UT Southwestern, has a tremendous wealth of experience in treating very, very sick patients. So she'll talk more about hepatitis C for those of you that just can't get enough liver disease. So her talk will begin at 12:40 and it'll go to 1:30. Our exhibits are actually open until 2, so we'd encourage you to mix and mingle with our sponsors, who we're very grateful for helping make this happen. And then you'll have about 20 minutes, her lecture starts at 12:40, to grab your hot lunch and bring it back here and make yourself comfortable. But we want to thank all of you for attending, and I'll turn it over to the ladies to close it out.
So this concludes our presentations, and thank you for your interest in learning about liver disease. Again, we welcome your feedback, and we look forward to your completion of the evaluation online, which will lead you to obtaining your continuing education credit. We look forward to seeing you again next year at our second annual conference, which will be scheduled sometime February in 2015. Please feel free to participate in all the other opportunities available today. And again, as Dr. Port had mentioned, the exhibitor area will be open until 2 p.m. for you to go by and learn more about all the organizations who have strived to promote liver disease education and management.
So we would like to, at this time, thank our sponsors, our exhibitors, and our conference staff again. I know Dr. Poordad mentioned it, but I'd also like to thank them. Without their support, without their assistance, we couldn't have had this conference be as successful today, especially with our first annual. And we look forward, again, to getting ready, planning for our second annual now, and hope you will join us again. So please remember to stop by and visit with our exhibitors. They'll be there until 2 p.m., and they have so much information of how they're also helping us to help patients take care of their liver. So again, thank you for being here, and hope to see you next year.